So, catheter-based valves are meant to treat aortic stenosis. And when you think about aortic stenosis, the way to think about it is think about the heart having two halves to it. A right half pumps to the lungs relatively low pressure, and a left half pumps to the body relatively high pressure. And each of those halves is designed pretty much the same way. There's a valve that lets the blood in, there's a pumping chamber itself, and there's a valve that lets the blood out. The aortic valve is the valve between the high pressure left ventricular pumping chamber and the aorta. The artery takes the blood to the entire body. And typically your opening for your aortic valve is about 3 square centimeters. When it's less than 1 square centimeter, which is less than a half an inch square, you typically have severe aortic stenosis. Most people we see are between 0.4 and 0.8 square centimeters square. So they're trying to push all their blood through a little hole about that big. And that's like going in your backyard, turning on your hose and putting your thumb over the hose. You know, the more you put your thumb over the hose, the more pressure builds up. And that's what aortic stenosis is like, the narrowing of the valve. Now, what we know about aortic stenosis, you tend to do okay until you get symptoms. And symptoms are either fatigue and shortness of breath, which are heart failure symptoms, chest pain or discomfort, which are anginal symptoms, or syncope or dizziness, which are blood flow issues, blood pressure issues. And once you get symptoms, any of those symptoms, not to be all of it, any of those symptoms, if I don't do something about it, you have a tendency to die. And your rate of dying is between 1% and 4% per month, depending on how sick you were when you started. Even at the low end, 1% per month is a bad disease. For some of the extreme risk older patients we do, the risk of dying is 2% per month. They're about 50% at 1 year if we don't do anything. Now the problem with aortic stenosis, there is no medical therapy for aortic stenosis at all. I can treat the symptoms, but there is no therapy for the stenosis. The only way to make it better is to take your thumb off the hose. So traditionally we've done that by me operating. I take your old valve out and I put a new valve in. It's a great operation. It's helped hundreds of thousands of people in the right people. The problem is about 1/3 to 2/3 of people that have severe aortic stenosis with symptoms, which make a class 1 indication for aortic valve replacement, never get a valve replacement because somebody's decided they're too old, they're too frail, they have too many other things wrong with them to go to surgery. So we've always looked for ways to treat these people. And one thing we did in the 90s was we were putting balloons in everywhere else. So let's just put a balloon in the aortic valve and blow it up, called a balloon aortic valvuloplasty. And we did that. And what we found is we can actually about double the valve size and about half the gradient. The problem is it always comes back, always. And so the survival is no better than medical therapy, which, as I said before, is no therapy at all. So people develop these catheter valves with the idea being that when we balloon your aortic valve, it's okay at the beginning, it just comes back. So if we had a stent that would hold the valve open, that would work, but if you have to put a stent in there, you gotta have a valve that works. So a guy named Henny Anderson went and made a stent out of stainless steel and got a pig from his butcher shop over in Amsterdam, sewed it onto this, crimped it on a balloon, put it inside this pig's valve and blew it up and made it work. And that kind of started the field of catheter-based valve therapy. Now there are 2 valves that are available in the U.S. right now. One is called the Edwards Sapien valve. It's a stainless steel frame with a bovine pericardial valve. Being stainless steel, you have to crimp it on a balloon, so you crimp it down on a balloon. You put that balloon inside the old valve, you pace the heart so rapidly that it's not ejecting, you blow up the balloon, that shoves the frame out, which pushes the old valve out of the way, you let the balloon down, which lets the new valve fall into place, you turn the pacer off, let the heart go back to normal rhythm, you got a new valve. The other one, and that's available commercially for people that are considered either non-operative candidates or high-risk surgical candidates, which by definition is an estimated operative risk of 15% or more. Then there's the core valve, which you see a lot of, and it's different. It's got a frame made out of nitinol. It's a metal memory. You can crush it up and let it go, and it goes back to its original shape. So instead of crimping on a balloon, you constrain it in the sheath, and as you pull the sheath back, it flowers into position. So instead of one shot getting it out there, we let it out slowly. In fact, I can have it 2/3 deployed, and it's in place and functioning, and I can look at it and decide if I like it. If I like it, I can let it go. If I don't like it, I can take it out. So I actually have a little more control. That was just approved by the FDA last week for extreme risk patients or non-operative patients. We're still enrolling in the trial for high risk, but anybody that's high risk can get a valve in the trial. And then we're doing the intermediate risk or TAVI trial, which are patients that are not low risk, but not high risk. They're intermediates, somewhere between 3 and 15% risk. And they randomize 1-to-1 between getting me operating on and putting in a normal valve or getting a TAVR valve. Now, the interesting thing about the TAVR valves that are out there is they work wonderfully well with getting rid of aortic stenosis. In fact, the gradients that we see are as good as any surgical valve I have. Issues have been stroke. In early trials, there was a little bit more stroke than there was with surgical valves. But the core valve extreme risk, which we just presented, was just approved by the FDA, The stroke risk at 1 month was 2.4%, and at 1 year was 4.2%, which is no worse than we would expect in a surgical group of people whose average age was over 83. So that's actually getting down to surgical type numbers. That's really not the issue that we thought before. The other big issue is leakage around the valve. When I do a surgical valve, I cut the old valve out, clean out the calcium, sew a new valve in nice and tight, it doesn't leak around the valve. Whereas this one, we leave the old valve in place, and it's all calcified, and we're shoving it out of place, and we're trying to form it to this very irregular thing. And so there's often a little bit of paravalve relief. As long as it's mild, it seems to work. In the partner trial, which was the SAPIEN trial, the risk at 1 year of having moderate or worse paravalve relief was about 12 to 14%. In the core valve trial, it was 4%, which is about what we see in surgical valves. So again, they're starting to get closer and closer to what we see in surgical valves. We can put these valves in a number of different ways. We prefer to put them into the femoral arteries. If the arteries are big enough for us to get up there, we prefer to just go right in your artery and not have to open it. Clearly, that's the least invasive way. If we can't, I can put a core valve into your subclavian artery, do a little incision here, do a direct aortic, do a little mini sternotomy, or the SAPIEN can actually go through the apex of your heart through a little thoracotomy. Once I get to opening your chest, it becomes a little more invasive, but we never put you on the heart-lung machine. And so these people, even these old people, tend to do a lot better. And even when we do direct aortics, in the hybrid room, we wake you up right at the end of the procedure. You leave talking to us. And so most of these people do very well. And in fact, we're starting to do some of these, not the sternum ones, but the femoral ones, under conscious sedation now, with the patient awake. And I think as we move forward, we'll be doing more and more of those. So one of the concepts that we'd like to do is we pick people that we consider are high risk for surgery but relatively low risk for TAVR, is do these people, send them to the recovery room, and then send them up here. And most of these people, I think, are going to be fairly easy to care for. Unlike surgical, they tend to not have these big incisions. They just have something in the groin. So like a cath, you have to watch the groin. For SAPIEN, the risk of a pacemaker is no different than the risk for an operation. It's about 4 or 5%. For core valve, it's higher. The risk of pacemaker is about 20%. And so we often send them up either we leave a temporary pacer in for 24 hours, or we put on Zoll pads. Now, the ones that we'll probably send up here are people that already have a permanent pacer ring, so we don't need to worry about them. They already have a permanent pacer. And so we don't have to worry about getting one. We don't have to worry about heart block, because they already have that. And so most of these people, I think, are going to be reasonably easy to take care of. Now, there are going to be new valves that are coming down the pike. There's a new one called the Boston Scientific Sodra Lotus. I'm their global surgical PI, so we'll be a site, and we'll start that probably in the spring. It's a new type of valve. But they're all essentially the same concept, mainly going into the groin, mainly deploying these things. And then, the difference between this and surgery is that I don't use the heart-lung machine, and if I open your chest for a direct aortic, it's just a tiny opening, and these people tend to tolerate that, even the older people, fairly well. Now, that's a lot of talk out of my part. So, pacemaker higher for core valve, no different than surgery for SAPIEN. Paravalvular leaks are starting to come down to much better levels, but it's still something we look for. We know about that before we ever leave the lab. If somebody had moderate paravalvular leak, we wouldn't send them to recovery room. We send them to ICU. Those people would not come up. People that we think don't have a pacemaker, high risk for heart block, they're not going to come up. They're going to go to the ICU just like they always do right now. And then, we'll know about stroke because we wake them up right away. Now, half the strokes occur during the procedure, and half of them occur after the procedure. And so they don't all occur during the procedure. So it is very possible they can come up and have a stroke on the floor, but they can have it on day 2, day 4, day 6. So, if it doesn't happen in the procedure, the next most common time is the first 48 hours, but then it still spreads out over several weeks.
Do you see more post-op AFib with the?
We see less post-op AFib with transfemoral TAVR than I do with an aortic valve replacement, which is about 20%. But if I do a direct aortic or transapical, then it starts approaching surgery because I'm messing with the heart. But if I just go transfemoral, the answer is usually much less because I don't open the pericardium. Bleeding is clearly an issue, particularly where we go into the groins. We've got to watch that. These aren't 6 French caths like there's 18 French. There are 3 French to a millimeter, so 18 French is a 6 millimeter. When I tell you a catheter size in French, that's the inner diameter of the catheter that goes in there. So the outer diameter is always bigger. So if somebody tells you that an 18 French catheter, I can put an 18 French or 6 millimeter catheter through it. The outer wall is usually a millimeter bigger. So instead of being 18 French, it's closer to 20 French. So they're pretty big holes. The SAPIENs that we're using commercially right now, the small one, the 23 millimeter valve goes to a 22 French system. 26 valve goes to a 24 French system. So that's 8 millimeters inner hole. get close to 9, I don't know, that's almost as big as most arteries. Now, what else can I tell you about catheter-based valves? All questions are fair game.
How's the length of stay? Is it shorter or about the same?
No, it's shorter, and it's, you know, in fact, there's a friend of mine up in Vancouver right now named David Wood, who runs what he calls his high risk for surgery, low risk for TAVR program, that are people that are older, but otherwise fairly healthy. They think will do okay, but aren't really good candidates for surgery, that he gets them all out within 24 to 48 hours. So he carefully selects them. One of the interesting things about length of stay is when we first started doing this, we said we want to get everybody out in 2 or 3 days. But they're old people, so they need home health, et cetera, et cetera.
Mm-hmm.
If I send you home before your DRGs, geometric mean length of stay, and we use the surgical DRGs, so the one without a cath is like 6 or 7 days, one with the cath is like 12 days. If I send you home before the geometric mean, and I get home health care or any kind of other care, Medicare comes back from the day I sent you home to the geometric mean, and they deduct that amount of money from the hospital. They don't pay you for it. So I've become less anxious to get these people out early unless I know they're doing well enough to just go home. Because if they get any kind of care, they actually deduct money from what they pay us. And part of the problem right now is making these things economically viable. These valves themselves are very, very expensive. Surgical valves tend to be about $5,000, $6,000. These valves are $30,000 to $32,000.
Wow.
So really, it's like having a little car in here.
How long do they last for? How long do they last for?
Well, we don't know, because the first balloon expandable valve was done in 2002. The first self-expanding valve was did in 2004. The valves we're using now bear a little resemblance to those first set of valves that go in, because they've already been changed so many times. Just like the old days of stent, where you said, well, how was the stent going to work? They said, well, we don't know, because we quit using that one last year, and we're using a new one now. Now, I will tell you that we do have some data for these that got to 5 years, and they seem to be working at 5 years. Most of the people we're putting these in are older. The average age of the core valve extreme risk was over 83 years of age. If you're 83 years old in this country right now, and you get a surgical aortic valve replacement, and you survive your surgical aortic valve replacement, your mean survival is only about 6 years.
Wow.
So, you know, it's not like I need a 20-year. And most of the older people that I take care of, what they're really worried about is not how long am I going to live, but am I going to live well enough to stay out of the hospital, not be a burden to my children, not end up in a nursing home. They're coming and going from nursing homes. And in fact, the biggest mistake I made in year one was allowing ourselves to treat people that were so sick that even once I fixed their aortic valve, they were still going to be sick. So they were from a nursing home, in a wheelchair. I fix your valve, you're still in a nursing home, you're still in a wheelchair. It's like having a rusty chain. You replace one link with a rusty chain, you still have a rusty chain. If you have a chain that has one rusty link and you replace it, you got a good chain. So we start looking for more of the people that are in actually pretty good shape, but they're just older, there's not the chance for me to operate on.
I remember maybe 2 or 3 years ago when this valve thing started, the time the patient has to wait before the surgery was quite extensive, and they said you have to go through a panel. Is it getting easier now?
A little bit, but not entirely. So it's not like surgery where somebody, cardiologist sees you, they do an echo, they do a heart cath, they say you got severe stenosis at your corners. Okay, go see Dr. Reardon. He's going to operate on you. And I say, okay, I got next Tuesday open. Let's operate. These valves, even the commercial valves, we're required to show they meet certain criteria, or we won't get paid. And unlike most things in medicine where you can use it any way you want to, because as a physician you have the discretion to decide who to use it on. In this, if you don't stick to the IFU, which is the information for use, the agreed upon indications, they won't pay you.
Oh.
And so, if you might imagine, if I tell the hospital I'm going to bring in somebody that they're not getting paid for it, they're not real happy with me because these are fairly expensive things. And so, it's still, even for the commercial, it still takes a while to get everything we need. Everybody's going to need an echo. Everybody's going to need a CT scan, a pretty special CT scan. Everybody's going to need a heart cath. And so, these things are all going to need to be done. Now, for most aortic surgery, they need a heart cath and an echo. The difference is we need a CT scan, because I need to know the annular size to make sure that the valves I have will fit in the annular size of that patient. There's 2 commercial Edwards sizes available, Sapien. There's 4 commercial core valve sizes. So I can cover a broader range of annular sizes with the core valve.
How often are you doing the subclavian approach?
Very infrequently. We've done about 50 direct aortics and 1 subclavian.
Okay.
We just like the direct aortic. I have friends though, Tom Gleason at at University of Pennsylvania. Tom does a lot of subclavians. He likes it.
Okay.
You know, I just find that if your femoral arteries are little, your subclavian tends to be little. It's a very fragile artery. A good number of my patients already have had coronary bypass. They're living on a mammary. If I knock off that artery and their mammary goes down, they're going to die. So I'm not real keen on using the subclavian. But that's that's just my preference. There are people that use it quite frequently and do very well.
I couldn't find any data that spoke to the incidence, the percentage of incidence of brachial plexus injuries with the subclavian approach.
Almost never.
Almost never.
Yeah,
Okay.
I mean,
So it's very
I cut-
rare.
Yeah, it's
Okay.
very rare. So I cut down to the artery. I see the brachial plexus. So, you know, and I've done this a lot, so I know where the plexus is. So it's very unusual. Now, there are people in Europe that are starting to do this percutaneously. So they're ultrasounding the artery, poking the artery percutaneously, pre-closing it with a closure device, putting a sheath in, then pulling it out, tying down it without ever opening it up. That's a little more worrisome because, you know, you're not looking at it, whereas when I cut down on it, I actually see the plexus, I move it out of the way.
Aspirin and Plavix, what's the recommended duration?
Aspirin forever and ever, Plavix for 3 months.
Yeah.
Okay.
So Dr. Reardon, from a nursing standpoint, for us to be successful, what do we need to look for, to be on the lookout for?
Well, unlike a lot of surgical valves that come up almost all volume overloaded, because they've had a pump run, and it sets up an inflammatory reaction, your body sucks up all this fluid, and they get fluid poured in. Most of these people actually come up a little dry. And because we're not getting a pump run, we don't give them a lot of fluids are doing it. And so not infrequently, they need a little volume the first night. So that's a little bit different. Hello?
So y'all got that volume. Dry, low output.
No.
Any questions for that? Tavis are coming.
Is this because they're gonna be running the transvenous?
Okay. That's fine. I'm up at 9. I'm almost done. Get the balloon in for him and pack them, and I'll come down and check them. Not a problem, thanks. So, I'm sorry, what were we talking about?
Success.
You answered it.
Dry, they're gonna be dry, so we wanna.
Yeah, so they actually may need a little fluid, and they're gonna tend to be, for the most part, on the sick end. These are people that we wouldn't normally operate on, or would be at the high end of the risk that we're operating on, unless they're in TAVI trial and they're being randomized. And even then, they're the intermediate risk, so, you know, they're not gonna be the low risk people.
4 to 6 hours bed rest.
No, we out of bed, get up moving.
Out of bed.
And
Even with
then
that
first,
8 range?
first
Yeah,
evening.
because we're gonna, yeah, absolutely. So we close these people, we get these people out the afternoon of surgery.
Okay.
First
Yeah.
evening post-procedure, right?
Yeah, absolutely. You know, and if it's a cut down, then it's really easy because we've sewn it up. If it's direct aortic, it's really easy because we've sewn up the aorta and, you know. So we want to mobilize, these are old people, we want to mobilize them quickly. And one of the nice things is, you know, some of these old people, you put them down in ICU one day, that's all it takes. It takes them a week to recover. You know?
That's right.
I mean, that little redo mitral valve lady we brought, the synapse. I mean, they just, you know, they left her in the ICU an extra day and she's already nuts. Now, she'll recover, but,
Yeah.
you know, and she's only 72.
Yeah.
When you're 90, it's worse. When you're 85, it's worse. So, does that help?
Yeah.
Yep.
So
Very
when's the
helpful.
person coming?
Well, whenever you guys are ready and the recovery room people are ready, and of course you guys have my number. I'm always easy to get, so when these people come up, you have questions, y'all have my cell number. You just call me directly, you know, and I'll come help you with them. Okay? Thank y'all very much.
Thank you. Can we get a picture with you?
Yeah, you can, if I can stand up slowly.